Across Ontario, in every community, there are people struggling. Municipalities are trying to support those living with mental illness and addictions, and those who are unhoused. We're joined by three experts who will help us understand how these crises connect. Please welcome Dr. Andrew Boozary, primary care physician and founding executive director at the Gattuso Center for Social Medicine at University Health Network. I love that we're getting the applause, and this is great. I'll just do all the introductions, and then we can get a round of applause. You've got some fans here, Dr. Boozary. Camille Kenville, CEO of Canadian Mental Health Association Ontario, and Matthew Pegg, currently the Chief Operating Officer of Warrior Health, and will be Ontario's Deputy Minister of Emergency Preparedness and Response as of this October. Please, a round of applause for our guests. And congratulations. We'll be talking about that a little bit. I know you're all here so you know what we're going to be talking about, but I just wanted to give people an opportunity that we are going to be talking about some heavy topics, and if you need time to step out, please do so. And also, just for anyone watching, we are going to be talking about things that might impact your mental health. Dr. Andrew Boozary, I wanted to start with you, and I'm going to ask you the same question. We want to know a bit more about the work you do and how it relates to this topic and some of the solutions moving forward. So Dr. Andrew Boozary, what is social medicine, and how does that relate to the work that you're doing with supportive housing in Toronto?
Quick response. So I think in terms of a quick answer, I think when we look at social medicine, I think it's something that's not at all new for people in the room and for people who've been doing so much work in the city and local level. I think the reality of social medicine is that what drives health is outside the walls of the hospital and clinics. And this idea that, it's being here in Ottawa 50 years ago, Minister Lalonde issued the report of the health of all Canadians. And this idea of social medicine, Canada was a ostensible leader in social medicine, of this idea that the environment, the air people breathe, the jobs that they have, the social network, and whether or not they have access to housing are the largest drivers of health outcomes, or how long and well people can live beyond universal health care. So that's really the premise of social medicine in the Canadian context. And I think the argument is that this started 50 years ago in that report being a global leader, and Canada has really fallen behind on the areas and merits of social medicine. Minister Lalonde then was worried about housing, when 20% of the entire housing supply was social housing. There was non-market options for people. We're now at less than 4%, 50 years later. And I think these are the realities then when people are living half as long as the general public, when they're exposed to homelessness. And for myself as a primary care provider, these are the challenges and the Band-Aid solutions you can try to do in a shelter, an emergency department, and a primary care clinic cannot really undo the real pathologies of poverty that come from homelessness and from a lack of income support and disability support for people who are now, again, with AMO's excellent report, at over 80,000 people being exposed to homelessness in Ontario today.
And that number within the next decade is projected to increase to up to 300,000. We've also heard that housing has been described as suicide prevention. And Matthew, there are lots of people who are overlooked when we think about who is struggling with mental health. How does your work focus? What does your work focus on?
Yeah, thanks so much. And hi, folks. Really honored to be with you today. Since November of 2024, I've had the opportunity to lead an initiative known as Warrior Health. And Warrior Health is the implementation of Ontario's a strategy that the province of Ontario wrote and issued, known as the Mental Health Supports for Public Safety Personnel. And the reality today is public safety personnel and first responders in the province are more likely to die today by suicide than they are as a result of a line of duty illness or injury. And that's a profoundly disturbing reality.
Why is that?
These are things that I will say we're doing a better job. When I started as a firefighter, what feels like an eternity ago, 33 years ago or so, I will tell you, at that time, I never would have put my hand up and said, I'm struggling with what I saw today, or I'm struggling with what I had to do today.
Because you're supposed to be strong and capable.
Absolutely.
And,
The organizational response, notwithstanding fantastic people, the organizational response would have been, you know what, kid, you're probably not cut out for this. We're doing a much better job. By the time I left my role as the fire chief in the City of Toronto, I would walk into fire stations unannounced, and there are conversations happening around the kitchen table about resilience and mental health. And that's really important. And the work that we're leading in Warrior Health, that is a little shameless plug, it is available now. It is entirely free and it is anonymous, sponsored by the province. There are an incredible number of upstream proactive resources available to all of public safety across Ontario and their families, aiming at helping to enhance that access and reduce the barriers to those proactive supports. It's really exciting.
I just want to point out that for people who might not know, public safety personnel includes first responders, like firefighters, police officers, paramedics. And I imagine, what we see on the news is very upsetting, but these are the people that are on scene first, and they're experiencing what's happening to people within their community. So it does leave an emotional impact. Camille, how has your work at the CMHA expanded your understanding of who is affected by mental health and addictions?
Well, it has expanded to the understanding that we're all affected, and it might be directly or it might be a family member or a friend. And it used to be 1 in 5 that would experience a mental health issue through their lifetime. It's now higher than that. And the pandemic is something that in many ways we haven't come out of as it relates to our mental health. And on a much more serious note, in terms of the level of homelessness we're seeing now, we know 80,000 are unhoused in Ontario. We know we lose 7 individuals every single day from an opioid overdose due to a toxic drug supply. And these issues aren't easily solved, as we know. It's not simply a matter of building housing and putting people in it. The level of support that these individuals need to be and remain healthy includes things like, as Andrew was saying, food security. The level of poverty has never been higher in our province than it is now. So these challenges are enormous, and they take all 3 levels of government to come together. Everybody has a role to play in this, along with community partners across the board, to look at these issues and to see where they fit into the solution.
I'm glad you mentioned the pandemic, because I was reading an article that featured you, Matthew, and I don't know if a lot of people know. I didn't know until I read it, but for most of the pandemic, you were living in a hotel away from your family, and you were receiving death threats, and you required police escorts. Like, you were told you cannot leave your hotel room without the police escorting you.
Very true.
You and a group of other people were working day and night for the City of Toronto, and that was happening throughout the province in different municipalities, dealing with this once-in-a-lifetime event, and you're receiving death threats. Can we just talk a little bit about the pandemic and how that changed all the things that we're talking about: addiction, mental health, housing?
Well, sure, I'm happy to start. The response to the pandemic and the realities of the COVID-19 pandemic, in my experience, and I was very privileged, I had probably the ultimate front row seat to watch all of this unfold. It did a couple of things. It exposed the greatest part of humanity I've ever seen. I watched people step up to do things that no one ever imagined they were going to do, and just continued to give and give and give of themselves as part of a group effort to help get us through. So I had the privilege of being a part of that and watching that happen. It also created some really significant challenges, and fitting we're talking about mental health, because it exacerbated a lot of pre-existing mental health issues, and I was one of a large number of people that became the recipient of some pretty negative behavior, and that was, I guess, from a professional standpoint, really just became part of the job, and I will forever be grateful and eternally thankful for the Toronto police officers and the law enforcement people that kept me and my family safe so I could continue to do my job as the incident commander. Absolutely.
And Dr. Buzari, thank you for sharing that.
Thanks.
Dr. Buzari, we know that we talked a little bit about the situation that's happening in the province. It was last year at AMO when we heard that over 80,000 Ontarians are experiencing homelessness. We know that Ontario has a housing crisis in addition to a mental health and addictions crisis. How do these issues reinforce one another?
Yeah, and if Nam, if it's okay, because you suggested to play with each other's great answers, and I think from Matt's really important answer on that, I just would want to underscore one thing through the pandemic as well. You know, I think there was great mobilization of efforts to house people, right? I think, and there are people in the room that were part of that, trying to find hotels or various spaces when there were thousands of people that were really at risk of COVID transmission. And we mobilized housing at a rate we've never seen before. And I think many of us were surprised that we could move people into housing. Patients that were at risk in hospitals were moving into hotels as housing. And we've pulled away from that in a really dire way. And I think the report that you're mentioning of over 80,000 speaks to that. And I think Matthew's answer in terms of the great humanity and also the fact that every level of government could work together so quickly to come up with these solutions. The challenging piece is that when people who are unhoused are no longer a threat for COVID transmission, how much do we really care to now mobilize these efforts where people outside the building today are suffering and surviving homelessness at a rate we haven't seen? And so when the question about mental health and the pandemic, or mental health and homelessness, my take on that is it really runs both ways. So if someone has mental health challenges in general, they're more likely to be unhoused. But the longer that you expose someone to homelessness, the longer that someone has to deal with the precarity of not knowing where they're going to sleep one night to the next, that also exacerbates health conditions, and particularly mental health issues. So, you know, the longer, you know, hearing that, you know, the homelessness crisis is really a mental health issue or it's a drug issue, that's not true from the data that we've seen. Obviously, the homelessness issue can worsen and drive worse mental health outcomes. But fundamentally, I think it is about ensuring that there's housing first, that there's housing as a human right, and as Camille mentioned, that there are these supports that people need, especially if they've had to endure homelessness for so long. Of course, they're going to have really serious comorbidities of mental health and physical health as well.
I think there is a perception, maybe it's like a stigma, that people who struggle with addiction, maybe it's a moral failing on their part, it's their choice, kind of like you made your bed, you should lie in it. And there is a perception that severe addiction leads to homelessness. Is that true?
Again, I think we really have to push back on the stigma and the myths. And so I think this idea that homelessness is a personal choice or personal failing, I think flies in the face of so many decades of research and evidence that these are really policy failures. So I think when you go back to our first conversation around how much social housing access or supportive housing access was in place even 30, 40 years ago, individuals weren't making that choice to not get access to housing. These were policy decisions from every level of government, of every sort of party over the last 30 to 40 years that have resulted in where we are today. And I think this idea that the onus is on individuals and it's their own failing, it to me is one of the gravest mistakes we've been making when it comes to how we're approaching this problem. And I would again even push further that this idea to criminalize or punish people in poverty comes with far worse costs and far worse outcomes for people's own mental health. So I think, the addiction piece is definitely important, but people need help and supports. And I think it's cruel to tell people you need to recover from a serious substance use disorder when 300 calls a night, for example, in the city of Toronto are being unanswered to get shelter. So what impossible decision and what impossible situations people are being forced into?
Could I add to that, Nam? I think Andrew's 100% right. We actually even did a public opinion poll with Polara Research to see what the views of Ontarians were with respect to people who were homeless or had an addiction on the street. And we wanted to know if there was comfort with a criminal justice response or a healthcare response. And it was overwhelmingly in favor of a healthcare response. 80% felt that this is actually a health issue for that individual. And I think we have to break down who we're actually talking about, because I think the average person might assume somebody who has an addiction and is on the street is by very nature dangerous, and they have led a life of questionable choices. Most often, it's somebody who actually has a job and a mortgage, and they may have children and a family. There are people that were injured on the job. We know the construction industry has the highest rate across employment around opioid use. They are treated for their injury, but the pain remains, and they begin to spiral into getting illicit drugs, and that unravels their life. And I've heard this story across the province, and it very often takes the same trajectory. And sometimes it ends up with that individual losing everything and becoming homeless. And these were people that were contributing to society not long before that. So defining who we're talking about and thinking about what actually is in their best interest and our collective best interests will reduce that stigma a lot.
I also just wanted to add that for one of the shows that we did on TVO, we went to an encampment, and I spoke to a young woman in her early 20s who said that when she grew up, she did everything that she was told to do. She went to high school, got into U of T, and in year 3, she experienced some personal hardship, and she ended up on the street, and she never had done drugs before that. She said, if you're living on the streets, of course you're going to start using because you're trying to just cope because of the things that she saw. I just thought I would add that as well.
No, it's very true. It's the relationship that I think you were referencing. It's the homelessness led to addiction. Sometimes addiction will lead to homelessness.
And the people who are responding to some of these incredibly hard events that are happening on the streets of whatever city we are in this province are public safety personnel. And many of them are also struggling with mental health issues themselves. Matthew, what are you seeing on the ground?
There are people that are struggling, for sure. The demands that all of you good folks administer and support and lead, and those services you administer, all of those public safety personnel that are working day and night, providing, they're doing difficult work, and they're quite frankly, I would openly talk with firefighters about the fact that when we would onboard them, I would say, we're going to make you see things I wish you didn't have to see. You're going to have to do things I wish you didn't have to do. And there's no way around having to experience those things in support of public safety and in the performance of your duties. What matters, I really think where the value is when leaders and when employers and when a leadership body together is willing and able to invest and focus on providing those proactive supports and those resilient supports so that we're not going to prevent public safety personnel from seeing the things that we don't want them to see, but we can equip them with the tools so that those exposures don't automatically become illness or injury. We can give their families the supports so that the supports that my family never had when I started. So the fact that there are supports available today for partners and spouses and children and that broader public safety community, because those impacts aren't just being felt by Ontario's public safety personnel, they're being felt by their families as well.
Because you kind of bring your work home, right?
100%.
It's hard to separate that. Camille, in CMH's pre-budget submission, you reported that 3% of healthcare funding goes toward community mental health and addictions. Is the solution as easy as more funding for those organizations?
It's easy to say it's only about more funding. That's the crux of it. For us, in reference to that, we were talking about compensation for our frontline staff. And frankly, I wouldn't compare them to first responders, but it is exceptionally challenging work. These are the individuals that are going out through the night to help people who are homeless, bringing them in, and in many cases providing food security. They're traditionally paid 30% less than hospitals and school boards. And so really, there was a collective effort on behalf of community-based providers, some of whom are in the audience today. My colleagues, who are very talented, came together and said, why don't we make a case to government that actually demonstrates in the cold, hard facts with compensation analysis what the delta is between folks paid in hospitals and other sectors. So that's a reference to the need to increase the overall amount of funds that go into community-based mental health and addictions care. That said, that's one piece of it. It's obviously much broader than that, and it involves the work that we're doing related to supportive housing, the work that we're doing on many, many fronts. We're also in the first responders business. We're in, we help, in fact, frontline healthcare as well on many fronts as it relates to trauma and ensuring that they have the skills to manage their mental health.
We only have about 20 minutes left, and I want to squeeze in some questions. If you could just quickly explain this next part for me. In the pre-budget, it also reads, investing in mental health and addictions infrastructure will only lead to economic benefits over time, as research shows that every dollar invested in psychological services in Canada saves society $2 over the long term. Can you please explain how that works?
Certainly. I'll do it in the context of supportive housing, which simply put, in comparison to an individual being in a hospital bed or worse, incarcerated, or in another institution, supportive housing at $4,000 a month is the cheapest deal. So it's the best for that individual, but it's the very best for taxpayers.
This is a two-part question to you, Dr. Bourzzari, because I'm trying to rush through the questions now. There's been pushback from the public on projects like shelters. How to help the public understand that housing like shelters are a solution to get people off the streets? And also, what do you say to people who think that supportive housing is too expensive to be an attainable solution?
Yeah, thank you, and appreciate your clock management. I'll try to help with this. So on the two-part question, I think on the first, one, I actually would push even more forward. Shelters to me, and I think to the room, are not housing. And I think the public, are right in that.
No, I want to know more about that.
And I think from a lot of the folks in the room who have vast experience with it, shelters are not housing. To me, they're very anachronistic structures that were in place during the time of the 70s and 60s, where there was much more transitional opportunities for people to be in a shelter for 30 days, to be able to then transition to housing. That's not the case now. What we see is that shelters are really institutions, they're not homes, they're not places where people can have their own bed and bathroom or their own safety and security. That's not to say that shelter workers don't work incredibly hard, but the conditions are really challenging for everyone who's involved. And really, when you have shelter capacity at 105, 110% every night, where mentioned hundreds of people can't access it, what I think we really need to do, and I think there's been a huge coalition pushing for this, is that moving away from the thinking of shelters to housing first and housing for all. And I think the realities that Camille had mentioned, I really want to look at the costs. When people say, well, we can't afford housing for all. Well, how can we afford the status quo? The AMO's report saying that if we don't intervene now with supportive housing investments, we're going to see a tripling of homelessness. And currently, if someone spends a month in the hospital that I work at, it's over $32,000 a month. It's $14,000 to $15,000 in the justice system, which a dear colleague of mine, Lana Fredo, calls the de facto mental health system, because I know many patients actually try to get into the prison system because they can't access housing and food supports, to around $6,000 for shelter supports each night. Versus the $3,500 or $4,000 each month for supportive housing. So I think it's more cost effective, it's more humane to have housing versus shelters, and I think that's really where we need to push our collective efforts with every level of government.
I want to do a quick follow-up with Camille on housing first, because it is an idea that comes up a lot in conversations about mental health and addictions. What does that look like to you?
Well, we're sitting in the city of Ottawa, and the Canadian Mental Health Association Ottawa branch is Canada's largest housing first provider. And they are doing an exceptional job with 500 units that is scattered. And by that I mean, instead of a congregate living where you would have a building filled with people in need of supportive housing, they live throughout the community. Often a building might have one individual who is being supported by our branch. And that reduces stigma incredibly, as you might imagine. It allows that individual to live fully as best that they can. But Housing First is really the fundamentals in terms of how do we get it right. If we're going to actually provide supportive housing to individuals and have that stick, so to speak, ensure that they will stay housed, ensure that they will stay as healthy as possible, you house them first, and then you build the supports around that person. Very often it's case management, ensure that they're taking medications should they be needed, ensure that they're going to appointments as needed. And from there, what's fascinating is the Ottawa branch, having been very successful at this, looked at specifically housing individuals with an opioid disorder. And they took the model, built Housing First into what they called Full House. So the City of Ottawa showed great leadership and put a motel aside. 10 individuals were chosen who all had addictions. They were able to go into this, what they call an island of respite in the motel. And from there, various supports were built into helping those individuals. So again, first issue was supportive housing, building in the supports to get them into recovery, which was critical, but then everything else that of course they would need, including peer support, which is very important for people on their journey, and then the basics of life, food, etc., and then housing that was more permanent in nature. And that project that was undertaken here has shown great results. All of those individuals continue to be housed and continue to be in recovery. So this is the point. We know how to do this. We know the research, we know what needs to happen. We need the capacity to do it, we need the funds to do it, and we need all of the partners together, including 3 levels of government.
And Matthew, 2-part question for you. If more unhoused people could get supportive housing, how would that change the day-to-day work of public safety personnel? And would that be a way to retain workers in those sectors?
Yeah, I think there's a direct correlation. The more proactive and community-based supports that exist, the less draw on 911 and the emergency response system that exists. And that reduces the demand on, from a municipal perspective, it reduces demand on responding fire service, on responding paramedics and police intervention. So there are direct offsetting cost avoidance that I think it's really important that get calculated, probably calculated by people a lot smarter than me, but those things need to be calculated and understood. And there is a corresponding, of course, so there's an economic benefit to that, but every time we can reduce the demand or reduce the service level demands on each of those services and all that broader public safety system, including healthcare, resulting in less traumatic and occupational stress exposures to the people that are responding to those incidents. So there has to be a net benefit in overall mental health and resilience impact across the board for the people that are being served and the people that are serving.
Dr. Bouzari, I'm going to come to you because we're just running out of time. But Camille, you can add your point to this question. This year, Ontario saw the introduction of homeless and addiction recovery treatment or HART hubs to replace safe consumption sites. How has the rollout, has it been effective?
I'm going to, if I may, add a little bit to what Matt said, because I think this is a really important point that we have at our branch in London, Ontario, we have a crisis hub that is serving individuals who are in a mental health crisis. So police and paramedics can drop that individual off at our branch as opposed to an emergency department, which alleviates the need for that firefighter, police officer, or paramedic to sit with that individual in an emergency department. Instead, their transition is 14 minutes as opposed to 6 hours in emerge, and they get the level of care and treatment they need on the spot. And I just wanted to put that one on the record.
Thanks for adding that.
HART hubs are rolling out across the province. We are actively participating in that process. And I think at the end of the full scale of that model, which includes housing, were we to get there over time, I think that it will work very well in communities. I think we're a ways from that as yet, but it is bringing partners together in new ways, and I think contributing to assisting individuals on the ground in different ways than we did. There still needs to be a harm reduction component, and that's something that I think over time, again, we'd love to build in, but we are actively working on implementing them.
I do wish we had more time because Dr. Bouzari, it was really interesting when Dunn House launched, how that went viral. Could you quickly talk to us about that?
Yeah, I mean, I think the answers here on this, really, I think, underscore there's such need for these upstream solutions. When I mean upstream, the realities are that people are resorting to emergency departments and hospital beds because they have nowhere else to go, and that the emergency department in many ways has acted like the last thread of the social safety net. And so when you see social assistance rates haven't increased, you see more and more issues around mental health and addictions, more and more homelessness, it's really challenging for how the hospital and healthcare system is supposed to respond.
Because it's already strained too from everything.
It's strained, and you're so limited in terms of what you can provide. I mean, you do everything you can, the nursing, social work teams, physician teams, to try to offer Band-Aids to now mental health and physical health issues that are far worse than they would have been if people had access to housing and primary care years prior. So the Dunn House example, I think, is one around trying to think differently and act differently of how we can have concrete examples to try to address this doom loop that happens where people cycle in and out of the emergency department or hospital bed. And at University Health Network, we had around 51 individuals that had over 3,000 emergency department visits in the year prior because they were unhoused, their health conditions were worsening, and it was clear that we weren't going to be able to help them change or shift their health trajectories. And so that was really the impetus and the drive to launch Dunn House in partnership with the City of Toronto, the provincial and federal government, their involvement and their investment, and then with the United Way and Fred Victor as a housing operator, because I think everyone in the room would agree you would not want the hospital as your landlord. And so I think that's some of the elements of understanding the humility of what we can do well at the hospital level, but where there's so much community expertise and housing and supportive housing, and bringing resources differently together. And we're already starting to see some major shifts in people's lives now, 7 or 8 months in.
In what ways?
Well, we've seen individuals that, again, were coming in with some very serious mental health and addiction issues are now leading recovery groups. We see people who have been known to peer support worker teams in the emergency department, and now, God willing, in the next few months, will be peer support workers helping other people. So and this is still, again, relatively a short period of time. When I know people want to see a silver bullet, and one, I'll be really clear, 51 housing units is not going to end the homelessness crisis. But when you look at, and I appreciate there's one person who knows that we have to scale Dunn House.
Is that your mother?
I can't see the individual, but I know my mom is probably working right now. So I'd have to say that, I think we have a real need to scale. And I think the other element on this that is just really important is that people are given these opportunities, and that they, really deserve these opportunities when it's been so long. And we're talking about people who are palliative. We're talking about people who are older adults, young folks that are losing their life years and opportunities that have all been part of Dunn House. And so I think this, to me, is where we really need to see it, instead of shelters, instead of criminalizing, punishing people, housing options. And I think that's really what we hope to see across the province.
I wanted to do I'd like to do a follow-up regarding heart hubs, because that's going to be what's in the province, and safe consumption sites have been shut down or are shutting down. Political leaders across the province have different views on people who might not want treatment for whatever reason. Some municipalities want the option to force some people into mental health and addictions treatment. What do you think about this approach?
I have a real issue with the way we think and talk about people who use drugs or who use substances. And I think just one example of where this has come up, I think we have this with respect to Dunn House, which we've talked about, of where people, not everyone, but a number of people have mental health and addiction or substance use issues that have been there. And I remember being at a breakfast, and someone, was well-meaning, and I think it was on Bay Street, so I had to dress like this, and was having the conversation, and they said, we really agree with Dunn House. We're willing to invest more. We want to see the government invest more, which I thought was exceptional and great. But what about people who use drugs? If they use drugs, should they be able to have access to the housing? And there's just a lot of people in the room, and so I had to think about it, and I sort of said, well, I understand that, but I don't think anyone is going down Bay Street in the condos and asking people, who's drinking on a Friday night, right? And I heard that there's people on Bay Street who use substances. You know, and I think that's the reality of where if we have this, why this view of complete abstinence for people who are trying to get into recovery, when we talk about the science around harm reduction, it's real, and I think there's a real prejudice and a real discrimination towards people who use drugs as if they only have value if they can show complete abstinence. And so I think we need to be clear about the real science and benefits to harm reduction, to clean needle exchange, to all of these things that we've seen over the last 20, 25 years in Canada especially, where we were, again, an ostensible leader. And to pull and go into a direction where we're willing to spend resources to punish and police people, as if that's going to help people get into better addiction streams and pathways, I just don't think it lines up with the evidence.
Camille?
I think that was very well said, and the Canadian Mental Health Association, being Canada's oldest nationwide charity, got to this place because our work is based on evidence and research. And I'll tell you, I've talked to a lot of municipal leaders about this over a long period of time, and those that are comfortable with the notion of involuntary treatment come to that, in my experience, in my conversations with them, from a place of compassion. And they genuinely believe that they will be able to help, and they want this person to have treatment, or they want their constituent to have the support that they need. There's not evidence that indicates that that is the best route, and in fact, it can be harmful. So I think it's unfortunate we're even having this conversation. If we had the capacity within the system that we need, this is not an issue. We wouldn't be talking about, do we have to force people into treatment? I think the other thing that needs to be said, which is quite obvious, is we don't have the capacity to treat people that are looking for treatment now, let alone taking people off the street and doing it involuntarily.
What's missing?
What's missing are all the supports that individuals need, including the Housing First model, for example, or many other methods around supportive housing, and the capacity that we've talked about on the panel across the board, and all of the social supports that individuals need to become housed and stay housed. And again, that's not, as I like how you said, there's no silver bullet, unfortunately, and it really does take all three levels of government, because you can put up a building, but that doesn't do it. It's really the people that are going to be continually serving those individuals, getting them the help that they need to live a healthy life.
We have about 6 minutes left, and I want to give you all 2 minutes each just to answer my last question. The work that you do is all so challenging, and your communities thank you so much for what you do. And you must have, individually, personally, some really hard days. What makes you hopeful? Matt, I'd like to start with you.
What makes me hopeful? Things like this. I think that it's actually more than think. In my experience, I will say we can impact and we can make a difference in the reduction of stigma. We can make it okay and increasingly comfortable to have these conversations when leaders are willing to stay present and be uncomfortable in that situation and just talk. And when good folks like you are willing to come to this room, and you're willing and collectively willing, whether it's here or whether it's at home, just being willing to have that conversation, to talk openly about the fact that community mental health is a thing, that public safety mental health and resilience is a thing, and just to be willing to be part of the conversation saves lives. It makes a difference, it makes it safer for people, and I think that the more that we are willing to do that, the more that we are willing to be present in those rooms, whether it's a one-on-one conversation in a hallway or a plenary session, that is how change happens. And it's hard, it's scary, but I think just being willing to be uncomfortable and stay in that place and have conversations and be part of a change that needs to happen in the world that I am coming from, making those positive changes for Ontario's public safety personnel, and how broad a spectrum that is. We make it better for them, we make it better for their families, and we create a healthier province when we're willing to be present in those conversations and do our part to eliminate stigma. So I appreciate that all of you are here.
Thank you, Nan. I would say that in my experience, that people who are working in the not-for-profit sector are by nature very optimistic. And it's I could say that given the colleagues, the wonderful colleagues I have in many different parts of the sector. I also agree with Matthew that the world has changed a lot, even since I've been in the mental health and addictions world. People are having these conversations. I'm really pleased that people are outraged to see homeless people in a society as wealthy as ours, and they're wanting to act on that, and they're wanting to talk about that and find solution around that. I'm really pleased when people openly talk about how their child or their young person is struggling and are freely admitting that they are not managing their mental health very well and they're concerned about them. Those were conversations that didn't happen not long ago. And so this evolution is a very positive thing. And I also think it's fascinating that government is looking at different cohorts, if you will, of individuals to start to think about how best do we serve them. We run programs for farmers in the farming community because their needs are so distinct from others who go into a workplace every single day. And you know, the creativity abounds in terms of what we can do. And lastly, and most importantly, I would say my colleagues on the ground are so exceptional that I just am continually amazed at what they do and how they do it.
I'm glad you mentioned farmers because I don't think a lot of people understand that. I think the farming community has a very high rate of death by suicide. So thank you for mentioning that.
Well, not surprisingly, I don't want to cut into your time. Not surprisingly, if you think about their lives, they have no control over climate, commodity prices, all of these things that deeply impact their well-being.
And Dr. Buzara, you have the final.
We've already
you got the 2 minutes.
Yeah. But Nam, I want to thank you for pushing beyond the panel, you know, these conversations and issues around social policy with your platform, as you always do, and your own experience to it. So I really want to thank you, and I know the panel does. And I just think that the other piece, you know, I think there's a privilege of being in this room with people who are decision makers, leaders, and who've been advocating for these issues for a really long time. You know, what Matthew and Camille said, I mean, I think it oscillates between rage and hope, or maybe there's some intersection between the two that I haven't unpacked fully. But, you know, I do think in terms of the urgency, it's there. But, you know, again, the hope for me, my biggest privilege is being one of the doctors at Dunn House, you know, every Monday, and being able to see patients, hearing their stories, hearing the hope that they still have. Even though, to me, clearly as a clinician, it's clear that we've failed people for a very long time, and the generosity and hope and spirit that they still have of wanting to obtain that dignity in their own life and set their own health trajectory. And you know, it's been amazing being able to be there at the clinic, and I can't tell you, like every week in the hallway, someone's saying, we're gonna get more Dunn Houses, one of the tenants, and they're adamant, and they are the biggest and I think most effective advocates for what we need to see happen across the province. So I really appreciate it.
I'm going to squeeze in one last question for you because you are one of the people that's really pushing this conversation. Why is this work important to you as a physician?
Well, I think as we mentioned, the connection to health is so pivotal if we really want to believe in improving health outcomes as all health workers do. I think that's there. And I mean, I think, you know, being here in Ottawa, I think early in my career I was shaped by amazing nurse like Wendy Muckle and Dr. Jeff Turnbull, who I think are, you know, rightful legends in the city of Ottawa for all of their work for many decades. And then ultimately, you know, to my parents who fled as, you know, refugees and had to spend time in the sheltering system, in social housing, and being born into social housing, I know that I had a lot of opportunity that many others didn't.
I wish we had more time for this conversation. Thank you so much for all of you being so generous with your responses. I think we've all learned so much in the last 45 minutes. Thank you.
Thank you.
And thank you for being a great audience. Thank you.